So, without further ado, I'm going to introduce Loretto. She's from the Agency on Aging. She is, I consider herself my friend too, but we're friends that see each other once a year. So, to me, she's the expert on Medicare. If you could hold your questions until after she's done, unless she asks you if you got a question about something, that'd be great, because we really don't want the questions to be on the tape that's going to be on Channel 6. So if you could hold your questions, that would be great. Right here is Trish Powers. She is from Walgreens, and today she is the one that's going to be offering our immunizations. And also, if you have any questions of her, she's here to answer those questions too. So, all right, we'll get going. Thank you.
Excuse me. When Kathy asked me to come, we were looking at our calendars, and the date that you meet in October didn't fit with my calendar, so that's why I'm here this month. But I told her that at that time in September, we don't have the Medicare cost data for 2017, which is what people are really interested in. So I don't know what I'll talk about, but I'll come up with something. So then I started making a list. What can I talk about? Why did I worry? There's plenty to talk about. And believe it or not, I didn't collude with Walgreens, but the number one thing on my list was it's the flu shot season. Medicare covers the flu shot at no cost to you. It is not subject to the Part B deductible or to any Part B copayment. Same thing for the pneumonia shot, provided that you get it from a provider who accepts Medicare assignment. Walgreens is such a provider. Medicare will pay them X dollars and Walgreens will accept that. So check with your doctor, but the odds are the doctor will strongly encourage you to get a flu shot. It prevents countless misery, and it saves tons of money and prevents some deaths, because the flu is no laughing matter. It's serious business, especially for seniors. The flu shot is one per flu season, and the flu season is the fall and winter. We are now in the 2016-2017 flu season. So if last year you didn't get it until December, it hasn't been 12 months, that's not a problem. We're in a new season now, so go right ahead and get it whenever is convenient for you. So that was number one on my list. Number two is IRMA. IRMA is the income-related Medicare monthly adjustment, which is a nice way of saying we're going to charge you more. If your income is over $85,000 a year for a single person, or $170,000 or more for a couple, you will pay a higher Part B premium and a higher Part D premium for a drug plan. If you're under those figures, you don't have to worry about it. If you're over that, you see on this memo, which I hope you picked a copy of, it tells you how much you will pay per person per month in addition to the regular Part D premium. We don't know what the Part B premium will be. I didn't put this part in writing because there are so many uncertainties, but I'm sure it's of importance to all of you. Social Security, okay, I'm using the mic, but is it not loud enough?
That's just for the camera.
Okay. Okay. Which one? The Social Security Administration gives a cost of living adjustment, COLA, every year if there has been an increase in the cost of living. And they determine that through complicated calculations based on what's called a standard market basket, all the things that most people spend money on, food and housing, rent or a mortgage, and transportation, and clothes, and so on and so on. And they do the calculation from the third quarter of last year, which would be July, August, and September, to the third quarter of this year. So the measurement period isn't quite over. We've still got another week to go. And then they have to compile all the data nationwide and analyze it and determine whether or not there has been an increase in the cost of living. Now, it's human nature that we're all keenly aware of prices that go up, and we're never happy about it. When prices go down, we just think, oh, I'm such a good shopper. I'm so efficient, I found a bargain. And some prices, of course, are more volatile than others. Food and energy, particularly gasoline, being the most volatile. But several months ago, the Social Security trustees predicted that the increase would be about 0.2%. Big deal. Last year, there was no COLA, and the year before, there was no COLA. Before that, we had had one almost every year since the 1970s. This is very unusual. So 0.2% was their projection. That would mean most people getting Social Security would get an increase of about $2 to $4 a month per person next year. As my kids would say, big whoop. We don't know yet what the Part B premium will be. For most people, the Part B premium is withheld from their Social Security check. So if the B premium goes up more than the COLA, that would mean your net Social Security would go down. That's simple subtraction. But that can't happen. There is a provision in the law that sets up this whole procedure that no one's net Social Security can go down because of an increase in the Part B premium. And that's called the hold harmless provision. It might go down for other reasons. For instance, if you have your Part D premium withheld from Social Security, which is your option, and that D premium goes up, that also would reduce your Social Security. That's your call. But it can't go down because of an increase in the Part B premium. So last year at this time, when there was no COLA at all, the Medicare trustees and Congress really grappled. If about 70% of all Social Security, 70% of all Medicare recipients were held harmless. So then the 30% who aren't held harmless would have to pay the entire increase. In other words, their own share plus the share of the 30% who were, of the 70% who were held harmless. That would mean that their premium would go up from $104.90 a month to about $150 a month. Now, this was at the beginning of 2016. Congress quickly realized that this was unfair to have so drastic an increase and would be politically unacceptable. So they had to come up with another system. So they sharpened their pencils and determined that if the increase in Part B costs were distributed among everybody on Medicare, it would have meant an increase from $104.90 to about $118.80. So that's what they did. They said the 30% who are not held harmless, who don't have their Social Security check reduced by the amount of their Part B premium, those people will pay the $118.80, while the 70% who are held harmless will continue to pay last year's rate, which was $104.90. So their Social Security check stayed the same in 2016 as it had been in 2015. The problem with that is there wasn't money to make up what those 70% weren't paying, that extra money that they were not paying. And that came to about $7.5 billion. So we're not going to have a bake sale to make up the shortfall. So they borrowed the money. The Medicare system borrowed the $7.5 billion from the Treasury, which is already in the hole. And then to pay back that $7.5 billion, they tacked on a $3 a month surcharge, $36 a year, from everybody who wasn't held harmless. So the official premium is $118.80 a month, plus the $3 surcharge. So people who were held harmless are paying $104.90. People who weren't held harmless are paying $121.80 this year. Are you with me so far? Now, why would somebody not be held harmless? The people who are subject to IRMA, which I just mentioned, the people who are affluent because their incomes are over $85,000 for a single person or $170,000 for a couple, Congress thought they can afford to pay the larger premium. People who are new to Medicare and Social Security who don't have anything to compare it with last year because they weren't in the system last year. And people who are on Medicaid as well as Medicare because the state, in our case Illinois, pays that premium for them. So the state pays the full premium. So those are the three principal groups who aren't held harmless, and they are paying the $121.80. Now for the coming year, we anticipate we're going to have the same problem, almost exactly the same, except there will be this small COLA, 0.2%. So let's just say for simplification that it's $4 a month for you. If the premium goes up $10, for instance, your $4 increase will not show up in your check. It'll go to pay last year's increase in the premium. You're still in the hole. You haven't been paying that premium increase last year. And the increase this year is not enough to make up last year's premium increase, much less the hypothetical $10 increase for the coming year. So you'll still pay $104.90, the same amount, and your Social Security check will stay the same. While those who were not held harmless, who are now paying $121.80, with this hypothetical $10 increase, they'll be paying $131.80. Now, I emphasize that this is guesswork. We don't know yet. So I hesitated whether even to mention this because it's so many if this, if that, if the other thing. But that's the principle of it. The people who are held harmless will not have a reduction in their net Social Security. The people who are not held harmless will pay the increase for 2017, just as they did for 2016, and they will also pay that extra $3 a month.
Is that carryover from 16 going to increase their base for 17? Are they?
No.
Okay.
If you don't like this system, don't blame President Obama. Don't blame the current Congress. Don't blame the Social Security trustees, and don't blame the Medicare trustees, because none of them really had an active role in this. This was decided by Congress way back in the 70s. You remember in the 1970s we had very rapid inflation, sometimes frequently double digit. And that was when Congress set up this system that determined how much the COLA would be and how much the increase in the Social Security would be. So if we don't like this system, blame it on your Congress member from 40 years ago, because the current people in office, both bureaucratic and elected, didn't come up with the system. That's as much as we know so far. But what I've been reading lately is that maybe that 0.2% is not accurate. We don't know. They knew they were doing crystal ball gazing when they came up with that 0.2 percentage point projection, and I wouldn't be surprised if it turned out to be more than that. But I don't have a crystal ball either, so that's as much as we know now. The measurement period won't end until the 30th of September, and then it'll be weeks, probably well into November, before we know what the COLA will be for 2017. But that's as much as we know right now. Okay, back to your paper. Starting on page 2, I gave you a long list of all the mailings that Medicare and the Social Security Administration and drug plans and Medicare Advantage plans will be sending out starting any day now. They include the Medicare and You Handbook, which you should receive every year, that you should put that in your medical drawer and keep it handy and consult it when questions arise. That's your first resource. Then the other really important thing that everybody who's in either a Medicare Advantage plan or a drug plan should get is called the Annual Notice of Change. That's a report that your current plan sends to you telling you what their premium will be next year, what their co-payments and deductible will be, what drugs they will cover. For Medicare Advantage, it tells what their costs for all the different medical services that you might receive. All of that information is in there. I had a call one year in January or February from a woman who was very unhappy because a drug that she took was no longer covered by her drug plan. And so we were casting about how she could get this covered. And I said, but they did tell you about this. And she said, when did they tell me? Said it was in the Annual Notice of Change. She said, do they expect me to read that? I thought everything would be the same. And I said, no, that's why it's called the Annual Notice of Change. At the very least, look to see what will the premium be, the deductible. Look up every drug that you take to see if it's still going to be covered next year. And if it is, how do they classify it? Is it a preferred or a non-preferred drug? Are there any restrictions on it? That's what you want to know. At the very least, do that much. It's not scintillating reading, but it's very, very important. So look in your mail for an Annual Notice of Change, and that should come by the end of this month, which is next week. And then hold on to it if you decide to stay in that plan for 2017. Then there are a lot of mailings about for people who receive extra help, which is the subsidy for Medicare Part D, and for people who are in Medicare Advantage plans. And they're all listed here and with a deadline. Some of them are on colored paper. Frequently we'll get a call at the office from somebody who says, I got this letter. And the first thing we say is, what color is the paper? Because that frequently narrows it down a little and we can identify it readily more than trying to read all the boilerplate. So look through this list and see which ones of these publications or reports or notices you can anticipate, and then watch out in your mail, and when it comes, read it, see if it applies to you, see if you need to act on it, and save it. Just put it in your Medicare file and keep it handy in case you need it. The enrollment period for Medicare starts the 15th of October. This is for Medicare Part D and Medicare Advantage. Starts the 15th of October and runs until December 7th. And if you make a change in your current plan anytime during that period, it will take effect on the 1st of January. The plans are counting on people just staying in the same plan that they're in now. That's human nature, just inertia. But I urge everybody, no matter what plan you're in, and I hope you're happy with what you have now, but don't assume that it will be your best choice for next year. It may well be, and then you don't have to do anything because you would automatically be re-enrolled for next year in the same plan you're currently in. But it could be that the arithmetic would work out that a different plan would be a better choice for you, because every year the plans can change their premium, their deductible, their co-payments, the list of drugs that they cover, how they classify each one of those hundreds of drugs, and whether or not there are any restrictions on those drugs. You may be taking more drugs than you were when you did the Plan Finder last year. You may have dropped some that you're not taking, and conceivably something that last year was a name brand is now available as a generic, and that changes the equation. So with all of those variables, there's a very good chance that a different plan would be less expensive for you. as a whole, over the whole year. There isn't enough scratch paper in the world if you wanted to do that calculation on your own, because there are 25 different drug plans this year in Illinois, and probably about the same number next year. And you couldn't do it even if you wanted to, because you don't have all their cost data. But you don't need to do it. It's all on the Medicare website in a tool called the Plan Finder. If you go to medicare.gov, right on the home page on the left-hand side, there's a button, Find Health and Drug Plans. Click on that and it will lead you through this process of the Plan Finder to identify the least expensive drug plan for you in Illinois in 2017. Before you start, draw up a list of every drug that you take, including the name of the drug, the dosage, and the frequency, such as I take atorvastatin 10 milligrams once a day. Every other drug that you take, put that on the list. Don't put the generic drug if you take the name brand. Don't put the name brand if you take the generic. Then you'll enter those into the Plan Finder and choose one or two pharmacies, including the one that you use now and one other one just to be thorough. And then the Plan Finder will say, for this particular list of drugs, here is the plan that will cover them at the lowest total cost. And it will tell you what each one of those drugs costs and what you would pay in January, in February, in March, throughout the year. Before you meet the deductible, after you've met the deductible, if you get into the donut hole, if you get out of the donut hole, all of that data is available for the least expensive plan. And then the same thing is available for plan number 2 and plan number 3. There's no reason to go down to plan number 25, but look at the top couple of plans. If it's the same plan you're already in is your least expensive choice for next year, then that's a cinch, you don't have to do anything. If it turns out that you'll save $5 a year by switching, you may think it's not worth it. That's less than $1 a month, I'll just stay put. That's fine. But sometimes you save a lot of money. I did this for a lady one time, it was several years ago, and I'm still basking in the memory of it. She was in the least expensive plan for that year, but we did a Plan Finder for the coming year, and we saved her $1,000. In 20 minutes of work, we saved her $1,000. Well, she was ecstatic, and I was thrilled because that's what I've been trained to do, and we did it, and it would just hit the payoff for her. So you're not likely to save $1,000. That's a rarity. But you might save $25 a month, which is $300 a year. I can think of a lot of things I'd rather do with $300 a year than spend it at the pharmacy. So do the Plan Finder or get somebody to do it for you. And I'm one of those somebodies. My phone number is on page 1 of your handout, down at the bottom. You can call me at 800-528-2000. Just ask for Loretta. Please don't wait until the last week of the enrollment period, because by then we're really backed up. But get your request in early with a complete list of all your drugs, and we'll be happy to do it for you. But take a stab at it yourself. It's not that difficult. I'm glad to help. I should say, when you do this, you can either do it anonymously, just giving your zip code, or you can say, my name is Bob Smith, and my Medicare number is such and such, and my day of Part A coverage began on this date, and then it will know what plan you're in now and whether you get any extra help and so on. You can do it either way, it's your call. I prefer to do it anonymously, that's what I usually do, but if somebody is getting extra help, you get a more accurate figure if you enter the personal data, but it's your call. So don't assume that your current plan is your best choice for next year. If instead of Part D, along with Medicare traditional A and B, instead of that, if you're in a Medicare Advantage plan, Now that's a managed care plan such as an HMO or a PPO or a private fee-for-service plan. All of that data is also on the Medicare website in this same section. Find health and drug plans. Health plan is what Medicare is now calling managed care plans. The choice of Medicare Advantage plans depends on where you live. I assume everybody here lives in Will County. When you enter your zip code, it will then just only consider the plans that are offered in Will County. Medicare Advantage plans contract with Medicare to serve specific geographic areas. For instance, a plan might say, we will serve Will County and DuPage County. So if you live in either of those counties, you can sign up for that plan. I live in Kankakee County, so I couldn't sign up for that plan even if I go to a doctor who's in Will County. I can only sign up for a plan that's offered in Kankakee County. So it will consider all those plans. When you do that, of particular interest to you is what providers, what hospitals, and what doctors are in that plan's network. If you are in a Medicare HMO, your coverage will only be if you use those providers in that network, except in an emergency. If you have a heart attack, if you are in an automobile accident, they will take you to the closest hospital with a trauma center, and you will be covered. But other than in an emergency, you have to use providers who are in that plan's network. If you're in a PPO, which is a preferred provider organization, they have a network, and if you use those providers, you pay a lower rate, but they will give you some coverage in non-preferred, from non-preferred providers. But again, if you want to keep using the doctors and hospitals that you have been using, look to see who's on the preferred list. Medicare Advantage is complicated, and most of what you might need to consider is not of general interest to all of you. But I urge you to use the Plan Finder and look very carefully at the annual notice of change that they will send you, because this is your health that's at stake. Many people, as a general rule, find that with Medicare Advantage, your total out-of-pocket expense will be less because you don't need a supplemental policy. And in fact, not only do you not need it, you can't get one. You may not have a supplemental policy with the Medicare Advantage plan. So your costs are going to be somewhat lower, but you have to play by the plan's rules, and you don't have as much freedom as if you were in traditional Medicare. That's a very broad generalization, but I think it is true. However, don't deal with generalizations. Look at exactly what your choices would be as a Will County resident and see what you want to do. During the enrollment period, you can switch from one drug plan to another. You can switch from one Medicare Advantage plan to another. You can drop Medicare Advantage and go back to traditional Medicare, in which case you probably want to sign up for a drug plan to replace the drug coverage that you used to get from Medicare Advantage. You can do nothing, and then you will automatically be re-enrolled for 2017 in the drug plan or the Medicare Advantage plan that you already have. And I'm not trying to talk you out of that. I just want you to check first to see whether that will continue to be your best choice. Then another thing I wanted to tell you about is what's called MOON, M-O-O-N. If you go to the hospital, you have symptoms that you fear are a heart attack. So you go to the emergency room and they do the preliminary tests, and then they want to keep you under observation. They're not sure whether it's a heart attack or not. So you're there overnight. You have not been admitted to the hospital, and maybe it turns out that it wasn't a heart attack, it was indigestion. That's a big relief. You were an outpatient under observation, and you will pay for whatever services you received under Medicare Part B, which generally means that once you have met your Part B deductible for the year, then you will pay 20% of the assigned rate for every service that you received, and Medicare will pay 80%. If, on the other hand, they admit you to the hospital as an inpatient, then Medicare Part A will cover your stay. In that case, you pay the Part A deductible, which this year is $1,288. The Part A deductible is not an annual figure. It is per benefit period. The benefit period begins for Part A the day you are admitted to the hospital as an inpatient, and it lasts until you have been discharged from the hospital and discharged from skilled nursing facility care if you need it, and you have been home for 60 days. If after those 60 days you go back and are readmitted to the hospital for any reason, whether it's related to the previous admission or something completely different, if you are readmitted after 60 days at home, then you're in a new benefit period and you pay the Part A deductible again. It is mathematically possible to have 5 benefit periods in the course of a year. It would be difficult, but it conceivably could be done. But most people don't do that, fortunately. But it isn't just a case of, do I pay the Part A deductible or do I pay for Part B care for all these services? If you are an admitted patient, an inpatient, for at least 3 days, and then you need skilled nursing facility care after you leave the hospital, Part A will cover it. And the first 20 days in the skilled nursing facility will be completely free to you. There's no charge. Day 21 to day 60, there is a copayment, which I should know. It's in here somewhere. 161, that's right, thank you. But if you were in the hospital as an outpatient under observation, Part B does not cover the skilled nursing facility care. So it's very important to know the difference. So if you go to the hospital for any reason and you think you're going to be there more than a couple of hours, you didn't just go in to have an x-ray and then you went home, ask, am I being admitted or am I an outpatient? And don't ask the person who brings you your lunch on a tray. Ask somebody who knows what they're doing. The doctor cannot just admit you because you asked and he's a nice guy. There are medical criteria that determine who should be admitted and who should not. But always, always ask. Because this is so important and so many people don't understand it, Congress recently passed a law called the Notice Act. And Notice is a clever acronym for Notice of Observation, Treatment, and Implication for Care Eligibility Act. Somebody really worked hard to come up with the words that would spell out notice. And that says, if you have been in the hospital as an outpatient for at least 24 hours, before 36 hours pass, so sometime in the first day and a half that you're there, they have to tell you, you are here as an outpatient under observation. You are not an inpatient. Even if you're upstairs in a hospital bed, in a hospital gown, eating a hospital meal, you're still an outpatient. They have to tell you this orally, and they have to give you a written notice, and that written notice is called MOON, the Medicare Outpatient Observation Notice. And you have to sign it to acknowledge that you have received it and that you understand it. So they passed the law 6 months ago, and it was supposed to take effect the 6th of August, and they had the MOON form drafted, so you just fill in the blanks. And then there were a lot of objections. People didn't like this section, and they thought that needed more detail, and this part was too confusing. So they skipped that deadline of August 6th, and the soonest it will take effect is sometime in October, but I kind of think it's going to be longer than that before this law requiring the notice takes effect. But you don't need a notice. You now know, I've told you, when you go to the hospital, if you go to the hospital, find out if you are an outpatient or if you have been admitted, because there's a great deal riding on it, both how you will pay for what you receive in the hospital and whether or not you are eligible for skilled nursing facility care covered by Medicare. Sometimes people are horrified to discover that Medicare doesn't pay for their skilled care in the nursing facility because they didn't have the 3-day hospital stay that qualified them for it. So the best surprise is no surprise. Don't get caught by that. Okay, switch to the other handouts that I gave you. One is pink and one is beige and one is on white paper. Oh, my helper needs to scurry around and distribute them. These are related to what's called the Senior Medicare Patrol, which is an effort to reduce fraud and abuse in Medicare. You know the old story about the bank robber Willie Sutton, and they asked him why he robbed banks, and he said, because that's where the money is. Well, now the irresistible target is Medicare. Medicare spends billions of dollars for millions of people, and so it is an irresistible target for con artists and thieves, many of whom are ingenious. If they would apply their ingenuity to honest efforts, they would just be world beaters. But they don't. They prefer to use Medicare. So as taxpayers and as Medicare beneficiaries, we want to curtail this. And you also want to protect the integrity of your medical records so you are not the unwitting participant in somebody's fraudulent scheme. The white paper, which is 8 or 10 pages long, is how to read a Medicare summary notice.
You get it?
Once a quarter, you should receive, at least once a quarter, a written statement called the Medicare Summary Notice that tells all the services you have received from such and such a date to such and such a date. And it tells you whether Medicare covered it, what the doctor or other provider billed for that, how much Medicare approves for that amount, how much Medicare pays, which is frequently 80% of the approved amount, how much you will pay. At the top of page 1 of your Medicare summary notice, it says, this is not a bill. So people frequently just pitch it, or they never look at it, they just put it in the file, and it never sees the light of day again. That's a big mistake. Look at the Medicare summary notice. Every service that is listed is something that you should have received. Pay attention to it. If the doctor, for instance, is billing Medicare fraudulently, whatever he told them he provided will be listed there. If there's a service listed that you don't think you received, speak up. Call the doctor's office, call Medicare, find out what the story is. Now, I'm not saying that everything that's on there that you don't remember is a scam. Maybe you were unconscious or under sedation at the time, and of course you don't remember it. Or maybe it's a doctor who looked at your test results. He never saw you in person, so you have no recollection of this person, but he did read your tissue analysis or whatever it was. So that doesn't, I'm not saying that all those things that you don't recognize are scams, but some of them are. For instance, there was a doctor in DuPage County who, within the last year or two, was billing, he was a podiatrist, and he was billing people for complicated foot surgery, when in fact what he was doing was basically trimming toenails and calluses. And he was billing for services worth hundreds of dollars per person. And somebody looked at her summary notice and thought, I didn't have surgery on this date. And she called it to the attention of the authorities, and then they started looking at all of his billing records, and they discovered that he was billing for hundreds of people for this same complicated service, which was a complete lie. he ended up going to prison, losing his license, had to repay all the fraudulent amounts that he had billed, plus hundreds of thousands of dollars in fines, all because one person looked at her Medicare summary notice. So I am deputizing all of you to do the same thing. When you get your Medicare summary notice, look at it and see whether you received everything that's on there. And if you don't remember it, inquire. Maybe you just don't recognize the complicated scientific term for the process, but you actually received it, that's fine. Maybe it was a mistake, it was supposed to be billed to the other person with a similar name. Then they should correct that mistake. But maybe it's fraud. So look at that and act on it if you have doubts about it. The two colored pages, the pink and the tan, are some tips to avoid two of the most common kinds of fraud with durable medical equipment like a wheelchair or a hospital bed that you might need, and home health fraud. As with so many things, a few bad apples spoil it for most of the rest of us. Most home health agencies are honest people who are doing their best to help you get better. And the same thing for most companies that sell durable medical equipment. But there are a few who will figure out a loophole or a weak spot in the system and do everything they can to sell you equipment that you don't need or a service that you don't need, or to provide you with a modest service or piece of equipment, but bill for much more. These are the two areas of Medicare that are most prone to fraud and abuse and scams of all kinds. So if somebody calls you and says, Dr. Smith thinks you should have your blood pressure checked once a week, so we could come out every Tuesday morning and take your blood pressure. How would you like that? Well, okay. No, not okay. A, do you have high blood pressure or any reason to think it needs to be monitored closely? Maybe you do. But if you did, the doctor would have told you. If you needed your blood pressure that carefully checked and that frequently checked, he would have mentioned this to you. Furthermore, you're not eligible for home health care unless you truly are homebound. Homebound, for Medicare purposes, doesn't mean that it is absolutely impossible for you to leave your house. But it means only with difficulty, only with assistance, only with careful planning can you leave. And in that case, Medicare will be happy to provide home health care. But it has to be under the doctor's order, and he has to have drawn up a specific list of these are the services that you need. So if this stranger from the Acme Home Health Agency calls you and says, we'll come and check your blood pressure every week, that is almost certainly a scam. If you wonder whether you need this service, check with your doctor. But if there's any doubt, hang up. Don't give them any information. If they show up at your door, don't let them in. Never let a stranger in your house. And call and report it. Because if they're doing that to you, they're probably doing it to 50 other people as well, and trying to charge Medicare big bucks for services that the recipients don't need. In some cases, not only are people getting services that they don't need or products that they don't need, but then later when they do, Medicare says, we're not going to provide a wheelchair for you because we gave you one a year and a half ago. No, they didn't. They gave it to somebody else, but it was billed to your account. Guard your Medicare number as closely as you would guard your credit card number, because without that number, they can't bill you. If somebody has a booth at the mall and they say, we'll check your blood pressure free, just tell us your Medicare number. If it's free, they don't need your number. Don't give it to anybody in such circumstances. They used to say that you should carry your Medicare card with you at all times, just as you would carry your driver's license. And then if, no matter what happens, you've got that with you. They don't advise that anymore, because if you lost it or a pickpocket got your billfold with your card in it, they now have your medical identity. So instead they say, keep it in your medical file. When you know you're going to the doctor or to get your flu shot or whatever other service might be billed to Medicare, get it out and take it with you for that day. Then when you get home, put it back. If it turns out that you do have an emergency and they take you to the emergency room and you don't have your card with you, the hospital is not going to say, sorry, we can't help you, you don't have your card with you. No, they will take care of you now, they will deal with the emergency and straighten out the billing later. So don't carry it with you all the time. If you like, you can Xerox it and black out the last 4 digits of the number and then have that copy in your billfold all the time. That way, if it fell into the wrong hands, they wouldn't have your full number. But don't carry your card. And that leads me to another point about both scams and your Medicare card. Congress has been concerned for some time about the fact that your Medicare card, in most cases, has your Social Security number or your spouse's. So if it falls into the wrong hands, you're very vulnerable to identity theft. So they wanted to come up with a new system of identification that wouldn't be related to Social Security and would still enable Medicare to do accurate billing, but not make us vulnerable to identity theft. And they passed a law directing Medicare to do that, and they gave them 4 years to come up with a system for new people. So anybody enrolling after this new system is in effect would get a new number, not their Social Security number. And then they had another 4 years to replace the cards of all of us who were already on Medicare. But they now think they're going to be ahead of schedule, a rarity in government service. And we think by 2019, the new system will be in place. So I can see it coming. There are going to be all kinds of scam artists just ready to call you up and say, we're ready to send you your new card, but we just need to confirm, what is your present Medicare number? Medicare is not going to do that. They already have your number, and they know your date of birth and your address and your mother's shoe size and everything else. They don't need to call and ask you your number. So this is about 2 years down the road at least, but I can see it coming. So don't fall for that kind of thing either. If Medicare or Social Security or the IRS or any other government agency calls you, or if someone claiming to be one of those agencies calls you, hang up, because Medicare will not call you as an initial contact. If they had a problem, if they needed whatever, they will first write you a letter about it, such as that list of all those notices that we went through. If then they need to discuss it further, they might phone you and say, this is a follow-up to whatever. But out of the blue, a call from somebody who says they're with Medicare or Social Security or the IRS, hang up. If it turned out that it was somebody from Medicare, their feelings will not be hurt because they're the ones that are telling us to hang up. So don't worry about it. Just hang up and they can get in touch with you in writing, and then you can pursue it from there. So that's my spiel without all this Medicare data. I wish I could come back in October, but I booked on the day that you'll be meeting then. We'll have interesting information about Part D, how many plans there will be, and if the premiums are going up and down and so on. But all of that data will be available on the Medicare website, and you can call me at my office or call the Senior Services Center of Will County, which is a SHIP site. SHIP is the Senior Health Insurance Program in Illinois, and there are comparable programs in every other state. And it exists for the sole purpose of helping seniors deal with Medicare and other health insurance issues. They don't work for any hospital, for any doctor. They have no allegiance to any insurance company, any provider. They only work for Medicare enrollees. And their only purpose is to help you be an informed consumer and make the correct decisions. So the agency where I work, the Agency on Aging, we are a SHIP site. The Senior Services Center of Will County is another SHIP site. President St. Joseph Hospital also has a SHIP site. Those are the two here in Will County, and there are other SHIP sites all over the state. And they rely heavily on volunteers, but they are very well-trained volunteers. And when I say well-trained, this is the SHIP manual. I know this whole thing by heart. I wish, but I keep it handy all the time because we use it frequently, and the help is always available. If you ask me a question to which I don't know the answer, and there are many such questions, and I can't find it in the manual, then I call out the big guns. I call Springfield or the Chicago office and get the people who do this full time. So help is always available from Medicare or from SHIP, and we would much rather help people make good decisions than have to straighten out the problem that results from a poor decision or an uninformed decision. So don't hesitate to call. So thank you for the opportunity to talk about this. I'm sorry we didn't have the data about Medicare, but it's all going to be available in about a month. Do you have questions?